I'm going to turn it over to Dr. Sisson and let the seminar get started.
Thank you, Sydney, and welcome everybody. It's great to see everybody here today. Today, I'm delighted to introduce Robert Montierth, who works as a project officer with the CDC's Division for Diabetes Translation. He has been supporting cooperative agreements with partners at the state health department level for nearly 6 years, and he oversees diabetes funding with 10 state health departments and advises all things pharmacy and diabetes related across the division. Before joining the CDC, Robert worked in various roles with the Indian Health Service as a clinical pharmacist, a pharmacy director, a grant manager, and health center director. And before that, he, like many of us, worked in retail pharmacy. But today, Robert is going to talk about the CDC's Division of Diabetes Translation and the recent work with pharmacists. So please welcome Robert Montierth. And Robert, take it away.
Awesome. Hey, good afternoon, everybody. And thanks, Dr. Sisson and Sydney for pulling this together and the warm welcome. Look forward to conversing with you a little bit today and sharing some non-traditional roles that pharmacists play at CDC. I'm just going to move past these credit slides, if that's okay. Hopefully you got the codes that you needed for that. So again, yeah, just thanks for having me here today to talk with you. I just wanted to give you just a little bit more additional background for context from what Dr. Sisson just shared with you. I am a public health service officer, so hence the uniform, but I'm detailed to CDC. Prior to that, I was with IHS, but with CDC, I work as a project officer, and that's on the state and local consultation team. As he mentioned, I support various of our funding recipients pursuing various efforts to help minimize the negative impacts of diabetes within large population groups. I also serve a dual role where I help guide the pharmacy activities and operations within our division. And the majority of what we do with our funding recipients is we work cooperatively with them and we advise them on various strategies that they can pursue in their work. And that's what I'm going to be talking a bit more extensively about today. Before I was in this role, there was another pharmacist, and she had been here about 3 years. But before that, there hadn't really been a pharmacist within our division that I work at CDC. So it's really exciting to see them look at pharmacy from the perspective of how we can assist in diabetes efforts, and so much so that they've integrated a pharmacist on their team within their division. So I keep pretty busy answering questions and helping with a number of activities that we're pursuing there. And so I look forward to sharing some of that with you today. But let me see if we can launch a Zoom poll just so I can get a better sense of where you guys are either practicing or looking to practice in the future. If you want to just pop in A through H there, if those are applicable. Seeing a little bit of variety there. Academia, awesome. Outpatient clinic, great. FQHC, awesome. Still coming in a little bit. More academia. So it's great to see that variety. I'm going to talk a little bit more about some of the specifics of some of those areas where our work is taking place. Even so much of you are with academia, and that's great. We've got some great examples of work that's taking place with some of our partners with colleges of pharmacy. So I don't know if you guys are able to see those results, but I'm going to go ahead and close that box now. So this is an organization chart, the current organization chart at CDC. Of course, we're a pretty robust or pretty good sized agency. There's, I don't know the exact number of employees, but there are about 30 pharmacists. So not very many relative to the total number. And we work across various centers within CDC. There's 10 centers listed across the bottom. The oval circle, that's the National Center for Chronic Disease Prevention and Health Promotion. That is where the Division of Diabetes Translation falls under. And when I was asked to talk about where CDC is promoting or emphasizing pharmacist involvement in public health, it is a challenge because I don't know exactly what's happening all across CDC, but I can focus today's conversation on what is happening pertaining to diabetes. And so that's where we'll go with today's slides. So within the Division of Diabetes, we view our public health challenge as an iceberg. And we have found this to be a great metaphor because more than 37 million Americans have diabetes. Yet lurking just beneath the surface are another 96 million adults with prediabetes at a very high risk of progressing to type 2 diabetes, among other serious conditions. And about 84% of these people don't know that they have prediabetes. So a real challenge exists here for us. Diabetes is also the most expensive chronic condition. And from data in 2017, we know that the total estimated annual cost of diagnosed diabetes was $327 billion, including $237 billion in direct medical costs and $90 billion in absenteeism, reduced productivity, and the inability to work. So a new colleague on my team, a new project officer, recently asked me, why is there such an emphasis in working with pharmacists in our division? And really it comes down to three main areas, right? So pharmacists, as you can tell here on the screen, we've got all three of these things. We have a deep understanding of disease states, and we are trained experts in effective treatment options. We're skilled in motivational interviewing, and we're able to, because of those skills, support proper health outcomes. We also have frequent patient encounters. Pharmacists are also able to develop a high degree of patient trust through our frequent encounters. We have a good, close working relationship with medical providers. And so that really sets us up. It really helps us to be in a position to help people in many ways. There's also several studies, actually there's quite a few studies that have been out for a long time that have documented the pharmacist's impact over the years in team-based care. And a couple of them that are foundational are listed here. The Asheville Project, which you may have heard of before, but that began in 1997 and concluded that patients with diabetes who received ongoing pharmacist support, they maintained an A1C over time, and their employers experienced a decline in their mean total direct medical costs. There's also the Diabetes 10 City Challenge out there, and they implemented an employer-funded collaborative health management program using community-based pharmacist coaching, some evidence-based diabetes care guidelines, and self-management strategies, which also saw positive clinical and economic outcomes for those who participated in this program for at least a year. There's been many other additional publications that demonstrate similar outcomes and the value and the impact that pharmacists bring to team-based care. And in our effort to work nationally across, the country, and especially in high burden and under-resourced communities, there just are so many gaps. And it's recognized and realized that pharmacists can bridge a lot of those public health gaps based on their accessibility. And so when you consider all of these things, the training and the experience, the documented outcomes in diabetes care, the access that the US population has to pharmacies, the approach to include pharmacists in our division's efforts is quite logical, and it's exciting to see that take place. One of the ways that we have engaged pharmacists recently is in the National Diabetes Prevention Program, or National DPP for short. In response to rising concerns about type 2 diabetes, thinking back to that iceberg I mentioned earlier, there's a lot of supporting evidence out there that Congress looked at, and they authorized CDC to establish the National DPP in 2010. The National DPP consists of a partnership of public and private organizations that work collectively to build a nationwide delivery system for an evidence-based lifestyle change program for adults with prediabetes to prevent them from delaying the onset of type 2 diabetes. And so if you've heard of the National DPP, or if this is the first time, you may be asking yourself, what is the evidence behind the National DPP? And the answer to that is a foundational study called the Diabetes Prevention Program, which ran from 1996 to 2001. And the intervention in this study involved a lifestyle change program that focused on calorie reduction and increasing your physical activity to at least 150 minutes per week. The results from this study showed that through this structured lifestyle change program, participants were able to achieve a weight loss of 5 to 7% of their body weight. And due to that, the study showed that those participants who did achieve that amount of weight loss were able to lower their chances of developing type 2 diabetes by 58%, which is pretty good. But for those participants over the age of 60, this program works particularly well, and that age group is able to reduce their chances of developing type 2 diabetes by 71%. The National DPP has 4 overarching pillars that are required in order to be successful. First, it needs a trained workforce of lifestyle coaches to deliver the program. Second, it needs to maintain national quality standards, and CDC administers that through the Diabetes Prevention Recognition Program. Thirdly, it needs a national network of program delivery organizations sustained through coverage by public and private payers. And lastly, it needs informed, activated participants, many of whom are referred to this lifestyle change program by their healthcare providers. As mentioned, in late 2010, the National DPP officially came about, and it wasn't very long after we launched it that we started to see pharmacies that were wanting to participate. They came in and applied, and in order to capitalize on that interest, we started to promote this opportunity to pharmacies, and we started to create some specific materials to help guide them in their approach to the National DPP. The Pharmacy Action Guide is pictured here. This is a resource that gives a broad overview of the National DPP from a pharmacist's perspective, or from the overview of a pharmacy. And within this action guide, it outlines various tiers or levels in which pharmacies can get involved. The easiest level, the lowest barrier to entry, is to just promote awareness in your pharmacy that there is such a thing as preventing type 2 diabetes, that you can do something about prediabetes. And so just promoting awareness is a pretty universal approach that pharmacies can take. The second thing that we encourage in the action guide is to maybe take it a step further and actually screen some of your patients who are at risk, or test them, and then refer them to organizations offering the National DPP within their community, in person, or to a virtual option that exists. And then the third tier or level of support that we encourage in our action guide is to offer the National DPP lifestyle change program within a pharmacy, within your pharmacy setting. And so recently we revamped our pharmacy action guide. We updated some guidance, some information in there. And we also changed some of our pharmacy examples of this work. And we've been able to include pharmacy organizations in that action guide, such as the American Pharmacists Association Foundation. We've also featured the National Community Pharmacists Association, as well as Virginia Commonwealth University. And we appreciate all the activities that we've seen come about from these national pharmacy groups and state pharmacy school. So just another question. Let's see if we can launch another poll. How familiar are you with the National DPP? First time hearing about it, you've heard a little bit about it, you know a lot about it, but have not been involved, or you know a lot about it and you've currently been involved or have been involved in the past. Okay, I think that's everybody. So first time hearing about it is the majority. A little have heard about it, being second. Knowing a lot about it is 23%. Being involved in knowing a lot is 8%. Okay, great. Thank you for participating in that poll. Another area that we're heavily involved in encouraging pharmacists to explore opportunities in is the area of diabetes self-management education and support, or DSMES for short. The Association of Diabetes Care and Education Specialists, or ADCES, and the American Diabetes Association are responsible for credentialing sites or organizations that follow an approved curriculum and deliver this service, helping pharmacies navigate the accreditation or recognition process and become a sustainable site for DSMES service is an area that we're also interested in supporting. We have a wealth of information out there on how DSMES operates, and that's included all in the DSMES toolkit that's pictured here that CDC has. We're also encouraging the establishment of systems that allow for bidirectional referrals or multidirectional communication that implements communication better between medical practices and community-based organizations, just to really enhance better healthcare communication. Improved efficiencies on the front of communication is really important because we feel it will obviously aid in timely point of care testing and treatments that we saw in COVID and with flu season and so forth. And pharmacies really getting into that space. But we also find that in order for physicians and healthcare providers to refer individuals with diabetes or pre-diabetes to pharmacies, having a mechanism in place that can allow that referral to take place is a valuable option for them to pursue. And so again, just another thing besides National DPP that we're supportive of is DSMES. And the last thing I want to mention also that we're encouraging the involvement of pharmacists on is in team-based care. So here you've probably seen the patient care process at some point in your career, your education, and pharmacists really have they've just been doing an amazing job for a long time advancing efforts with team-based care, injecting themselves into clinics and into a team role. And so many of our funding recipients, as I mentioned earlier, are state public health department staff. And when we were working with pharmacists across the two areas I previously mentioned and in team-based care, we got a lot of questions because a lot of the health department staff were completely unfamiliar with this approach of utilizing pharmacists like this. And since then, we've been able to see state health departments find ways to engage with physician groups within their state, and they've been able to help support this effort by fostering relationships where collaborative practice agreements or CPAs could be established. Having really the state health department promote opportunities with pharmacists has provided just a lot of credibility for pharmacists that we've been able to recognize, and a further collaboration, which is really important. So I mentioned that the majority of what I'm involved with pertains to helping our funding partners find opportunities to engage with pharmacists. And one of those high-profile cooperative agreements is known as DP 18-1815, or we just call it 1815 for short. And this is a 5-year funding opportunity for each state and Washington, D.C. to help support diabetes management and diabetes prevention efforts within their states. So this funding is allocated to state health departments, and they're encouraged to pick from a menu of options that are reasonable for them to accomplish as they pursue work within their state as it pertains to National DPP or DSMES. And we've been encouraging them to work with pharmacists. This was actually the first cooperative agreement that we heavily focused on encouraging them to work with pharmacists. And when we put this together, like I said, over 5 years ago, I was pretty nervous that we wouldn't have any interest in working with pharmacists. And I was just hoping that we would get 8 states who would be willing to explore this opportunity. And I was pleasantly surprised when the application and the work plans all came in. We actually had 45 of our state health departments select to work within the pharmacy strategy, which meant I had my work cut out for me. So next knowledge question, just to make sure you're still with me. If you can launch that poll question, Sydney, how many state health departments elected to work with pharmacy partners under 1815? I should have put 0 as one of the choices because that would have not been good, but I did have that concern that we wouldn't have any states who wanted to work with pharmacists. And we actually did. We had 45 states who selected to work with pharmacists. And since then, I've been able to recruit additional states to get involved with pharmacy work. So I want to talk a little bit about what we've seen happen in regards to this relationship with pharmacists and state health departments. And as I mentioned, we're currently in our 5th year of this funding cycle. Our funding cycles only go 5 years, so we're wrapping it up at this point. And I've tried to summarize the progression of what I've seen occurring over the last 5 years at our state health departments. First, we were able to see them try to scramble and find out what partnerships they had within their state that they could rely upon to help them with their pharmacy work. So they immediately went a lot of times to their colleges that exist within their state, which seems very logical. And they also went to their state pharmacy associations for assistance, or they identified some other pharmacy network, such as the Community Pharmacy Enhanced Services Network. And they built an initial relationship there. Once those relationships were in place, they utilized their pharmacy partners to understand not only more about the types of pharmacies and programs within their state, because they really didn't know a ton. They also learned a lot about the profession and what the pharmacist's capabilities are and the level of interest that pharmacists have in doing public health activities, specifically regarding diabetes. That third block that's listed there is where decisions were more or less fine-tuned in terms of where the best alignment of the pharmacy effort should be. For example, where does it make the most sense to focus on the work they're wanting to do with pharmacists? Should it be with starting medication management activities and team-based care, or are they more interested in National DPP or DSMES programs? And then once they figured out what they wanted to do, where would they want to do it? What parts of their state need these services? Where would it be most productive to launch some of these activities? That fourth block is more or less the phase that many states were getting into right as the pandemic hit. At this point, they were trying to help pharmacies with DSMES credentialing. They were launching pharmacy-based trainings and classes. They were trying to initiate some team-based care programs and collaborations. And a lot of that got sidelined for a little while, and it's come back, and it's ramping back up, and more pharmacies are offering these services in their pharmacies, and they're exploring ways to make sure that they're sustainable. There's just a lot of pharmacy-specific challenges when we go beyond the non-traditional role of dispensing medications through a PBM and finding out how to bill for services. How do we get in and receive some type of reimbursement? And that's been a struggle for a long time. It's now on the radar of a lot of our state health departments, and they're jumping in and trying to help find ways to help pharmacies become sustainable in offering these additional services. So these are just some of the specific pharmacy entities that state health departments have identified and have been successful in their partnership with in 1815. And I wanted to highlight some of these and provide some examples of where value was recognized on the state side. So schools of pharmacy, obviously, very strong partners. And again, I'm going to table that conversation for a little bit more later. But state pharmacy associations have just been fantastic in a number of areas. We know that they're great at identifying specific pharmacies within the desired communities of interest. And they're also helpful at involving the state health department to know what their pharmacy landscape looks like within their state. And then again, once they want to disseminate information and bring involvement and pharmacists to the table, these pharmacy associations have access to disseminating that type of information. We've seen CPESN state luminaries getting involved. They help identify pharmacies with the appropriate capacity for supporting some of this work, where they're enthusiastic the most to do this work, and just really putting activities into place on the ground. Pharmacy consultants is an area that was something that was a surprise that came about. We've seen some states feel like they need to contract or hire a pharmacist on their staff so that they can understand the work better, to realize where opportunities truly exist and how they can be efficient in obtaining impact for their work. Boards of pharmacy have been involved with some states where they've desired collaborative practice agreement enhancements, or just promoting that opportunity broadly from the board of pharmacy level to pharmacists. Some examples of pharmacy training entities that the states have pursued include outlets that support pharmacies in DSMES accreditation or recognition applications. So they provide that technical assistance in how to pursue that. They've also been involved with training pharmacists on billing for pharmacy services in federally qualified health centers and the establishment of physician collaboration agreement. How do you build that model, that business model, and get opportunities in front of physicians to get the buy-in? Kind of want to shift gears away from the state for a minute and talk about another funding opportunity that we have out there, and that's known as DP 1705. Again, we just call it 1705. And the American Pharmacists Association Foundation was one of 10 national award recipients for this. This started about the same time as 1815. This one is also in its last year. And the APHA has had a lot of strategic partners over the last 5 years, and they've seen a lot of things come together. Some of their partners include Kroger. Obviously, it's a national chain pharmacy grocery store. It's in 34 states. And if the Albertson acquisition goes through, then even a larger reach there and potential to expand some of the services that they've initiated. The APHA Foundation also became one of the very first CDC and Medicare approved umbrella hub organizations for the National DPP. And this allows pharmacies to work together collectively to deliver the lifestyle change program under one infrastructure. This is just a diagram, a crude diagram of what an umbrella hub arrangement looks like. And when we're talking about delivering programs like National DPP, DSMES, we know that pharmacies have a busy workload, they have a busy workflow process. And so building out a way that they can strategize and be efficient with their time is something that I think will resonate to a lot of pharmacies. The purpose of an umbrella hub arrangement is to really connect community-based organizations that are delivering the lifestyle change program with healthcare payment systems in a timely manner to help achieve sustainable reimbursement as soon as possible. A major benefit of building an umbrella hub arrangement for the National DPP is that it allows for easy sharing of resources such as your staff, your marketing, your improved efficiencies in data aggregation and billing consolidation. When you pull all those together from across multiple delivery organizations, it just helps with efficiency and expanding the capacity. And really, this is exciting for APHA because having a pharmacy-based umbrella hub just has a lot of great opportunities and potential for pharmacy and the profession in general. But beyond APHA Foundation, there have also been a couple other pharmacy-specific umbrella hubs that are exploring opportunities and are in the works of some level of becoming credentialed or recognized organization, umbrella hub organizations. So in addition to the work that I've already mentioned with APHA Foundation in 1705, they were also able to collaborate with the National Community Pharmacists Association on a project to recruit and enroll 300 participants in the National DPP. Both of these pharmacy professional organizations have been just a tremendous asset to our 1815 State Health Department recipients. So we've tapped into them numerous times to share insights and opportunities to collaborate and to really just make themselves available to discuss opportunities for engagement between public health and pharmacy. We saw a lot of that engagement happen with COVID, and they have been able to share a lot of ideas on how that can continue to perpetuate opportunities in these relationships. I just really can't say enough about how valuable our partnerships have been with these two national organizations in regards to our state health departments. The last project that I wanted to mention that pharmacy's been involved with, and it's also really exciting. It's not part of 1815. It's not part of 1705. It's known as Innovations to Grow Enrollment and Retention in the National DPP, or NGEAR for short. The National Community Pharmacists Association worked with pharmacy software solution company Omnisys and with the ADCES to assist 48 community pharmacies in becoming CDC recognized National DPP organizations. This effort wrapped up at the end of last year, so it's not currently still actively being funded and supported, but I think a lot of their work is still going on independently. And I think they're even working on a manuscript that will eventually be published that details the project more about what they did and what they're able to learn and see and what took place over that. Across the work with our funding partners, we have seen just a ton of things come together. Here's just a few gems with working with pharmacists that I've highlighted. And as you look at some of these, I just need to mention as an aside here, and I think it's worth pointing out because our funding partners, our cooperative agreement recipients, they've got a lot of restrictions on how they can use their money. One of those is that we cannot fund them. They cannot use their funds to pay pharmacists or pharmacy staff for direct patient services. The funding can be used to build infrastructure. It can be used to support delivery and sustainability of some of these infrastructure services that are needed, but they can't really pay people to do the work. So none of these accomplishments came from directly incentivizing pharmacy staff to provide direct patient care. And what I mean by that is, I'll just give a quick example. In Ohio, a group of federally qualified health centers was funded to convene stakeholders and decision makers at several facilities. And what they were able to do after they met is they were able to create collaborative practice agreements within their facilities. They were able to establish protocols within those facilities as well and develop patient outcome tracking systems. They were able to conduct satisfaction surveys with the patient participants who were involved, as well as the physicians, to understand how this workflow enhancement with pharmacists was impactful. And they found it to be very productive, and so much that they have found it to be a successful model that they are looking to utilize additional support from state health department funding to replicate some of this work. It really provided a lot of great credibility to establish this infrastructure in Ohio and to explore opportunities to, again, move the work forward with pharmacists doing these types of activities. Last year, about this time, actually, with all of the traction that we recognized with pharmacy work, our division prepared a new business item for consideration by the APHA House of Delegates. And with the support of NCPA and APHA Foundation partners, we were able to see the following policy statement pertaining to diabetes prevention and management adopted last March, which one supports the expansion of patient access to diabetes education, support, and prevention, including but not limited to the National DPP and DSMES. Two, calls upon public and private payers to expand reimbursement for pharmacists as providers of diabetes education, support, prevention, regardless of practice setting. And three, advocates for campaigns focused on increasing community wellness awareness and health benefits for diabetes education, support, and prevention. So those three things are important because it documents the pharmacy profession's commitment to the expansion of this work to shape the development of legislative, regulatory, and media advocacy activities pertaining to the role of our profession in diabetes services. Across the work with our funding partners, we've seen a number of exciting things unfold with many of our partnerships. Here's just a few details with what we've seen happen with colleges of pharmacy. We've seen colleges of pharmacy sponsor community events that allow students and faculty to screen, test, and refer patients to various diabetes programs. We've seen them develop courses and rotations that implement some of the principles involved into their curriculum. We've seen pharmacy schools become CDC recognized DPP delivery sites. And we've seen colleges of pharmacy do some credentialing and billing and some training for these services and create toolkits. We've seen them host stakeholder events to build payer community provider relationships that support pharmacies in providing diabetes services. And then we've also seen them be hosts for webinars where they feature physicians and pharmacists and how they can come together and discuss the benefits and the evidence surrounding pharmacist team-based care. So I guess kind of towards the end here, what's next with the work that we're encouraging from our division? We've got a new NOFO coming out, 2320, that's going to launch later this year. And what we've heard from our state health department partners so far is just positive reactions to their partnerships that they've formed with pharmacists. And that's really encouraging. Many have gone so far as to say that they feel that pharmacists are not only well prepared to do the work that they're looking to accomplish, but they're also very enthusiastic and creative in the way they do the work. So in our future funding opportunities, we'll be focusing on exploring opportunities to expand and to scale what I've already been talking about today, mainly meaning involving some of this work with chain pharmacies more, involving more pharmacy networks, and figuring out ways to meet the needs of the U.S. population when it comes to diabetes management and receiving the care that they need. We are also aware that there's challenges that pharmacies have when it comes to billing for services. And we're advocating for additional resources and technology that streamline sustainable options so that these services can reach more people, so that more pharmacies can be involved with this work. So I want to encourage all of you to really take a step back, hopefully at the end of this presentation, and think outside the box, out of the non-traditional opportunities that pharmacists can play, and encourage you to see if there's something more that you can do in expanding specifically work around diabetes, whether it's National DPP and working to prevent type 2 diabetes, or in helping people with diabetes manage their disease state a little more efficiently and receive better outcomes. Schools of pharmacy, again, you guys are with the School of Pharmacy. You guys have just been great in general at training students, referring people, and screening people who can benefit from these services. And just so many great things are at your disposal. You have great capacity to do this work, and I know there's a lot on your plate, but if there's opportunities to get involved, I encourage you to do so. If you've got something in the near future on a practice site where you're working or in your profession and you're looking for ways to do more and to be more in this space, reach out to your local or state health departments, find out what they're involved with. Again, you know who their partners are, their state pharmacy association or your college of pharmacies. Find out if there's something you can do at that level to be involved and to foster communication and further connections between pharmacy and state health. Here's just a list, and you'll have all these in the slides, just various resources that pertain to some of the things we talked about. We've created some videos that explain to a pharmacist like what the value is in helping your patient population move the needle for diabetes prevention and diabetes management. I don't think we have time to show you any of these, but they're only like a minute or two long. Take a chance to, when you get time, to look at those and see what else is out there. So one last poll question, and then we'll turn it into some questions that you guys get to ask. But what opportunities exist for pharmacies to help reduce the burden of diabetes in the United States? Yeah, so it's like most people have answered or are close. All of these are potential opportunities for pharmacies and pharmacists to get involved with reducing the burden of diabetes in the United States. Every little bit helps, every individual helps. As we consider this from a national point of view, we want to have the most impact as possible. And we want to see our vision at CDC in the Division of Diabetes Translation is to see the world without the devastation of diabetes. And so anything that you do, all of these things are appropriate depending on where your practice setting is. Some may be more feasible than others. But just want to encourage you to look for opportunities to once again explore ways that you can be involved with diabetes and pharmacist activities, being that you are qualified in so many ways to do this work. So the next slide, yeah, I think that was it. So I guess I can turn it over to, I don't know if there was any questions that popped up on the chat. No, it doesn't look like there was. So if there's any live questions or anybody who wants to throw questions in the chat, I guess we've got a few minutes, and Sydney, you can stop me if we're already at time, but or when we are at time. Okay.
Yep. So if anybody in the classroom, there's remotes around, feel free to ask a question, or anybody on Zoom, feel free to, ask.
Robert, thanks. This is Evan Sisson. Thanks for a great presentation. I like seeing the big picture of all the things that are going on. One of the things that we're working on, and I see Karen Winslow is on the call here with us from the Virginia Pharmacists Association. Karen and I work with the Virginia Diabetes Council, and we are still in process of trying to create that umbrella organization to help support pharmacies. I'm curious about the APHA Foundation and their umbrella, and kind of how that's structured, but then also what success they have had or plan to have as far as getting reimbursement for pharmacists in delivering DPP and DSMES.
Yeah, and reimbursement is top of mind. I mean, obviously, it's great to provide these services, and pharmacists are very altruistic in the way we operate. In many cases, we just are looking to do these things. But to really get scale and really to get traction and really make this sustainable, which is where we're focusing on, there needs to be a successful path to reimbursement. And so the pathway that the foundation went is they started offering the program, and they got it out there, and they got traction, and then they went through the CMS process to become a recognized umbrella hub. They are considered a non-delivery umbrella hub. which means they aren't actually delivering the National DPP lifestyle change program themselves. They are utilizing all of their partners, and those partners mainly right now are Kroger, but they are, I think, open to additional pharmacies coming in and being involved in their hub, and they serve as that point in the middle where they pull all the data aggregation. They submit the billing claim to Medicare, who does reimburse for this service, and then they dole out the reimbursement pertaining to which entity, which pharmacy saw which patients. And so they have a business model that they've developed and business association agreements. And they, I think, picked Utah as one of the first states. They're trying to do this by state. And so they're strategically doing this because some states have Medicaid reimbursement for the National DPP and others are in the process. And so they wanted to be in a state where they could not only serve those who had Medicare, but also those who had Medicaid. And there are a number of private payers in Utah that also will reimburse for this. So they wanted to start where they had the mechanisms in place, or at least the potential to receive reimbursement. And so that was their strategic approach, is to start off in those states where they had the most reimbursement viability as possible, and then from there expand out into other states. And I know they've got 3 states top of mind, but I think Utah is the first one, and I don't think they've officially launched yet. They just received their CMS MDPP approval last month, I believe early February, might have been the end of January. No, because I talked to Ben in February. It would have been in mid-February so this is all very new. And there are a couple other state health departments that are working to find a way forward. I think Wisconsin is another one that I mentioned on one of my slides. But yeah, finding out what your partnerships can do and where the sustainability makes sense is key. And Virginia Pharmacy Association has been tremendous. And I mean, you guys are doing things with your College of Pharmacy there, but then also we've involved Karen in a number of things, and she's helped explain some of the work that's that you guys are all pioneering in Virginia to some of our other state health departments. And so that's helpful to see that.
Well, and I'll piggyback off what you just said, Rob, because I think that your sharing what pharmacy does with all these other state health departments has been huge in moving the needle forward with them wanting to work with pharmacy. I know Virginia was sort of early on in that adoption, and so other states have come a long way. And your work on the most recent with NACDD and explaining how pharmacists, I think those calls are great for the state health departments to listen into and other partners, as well as I've learned a lot from being involved in those calls as well, because your subject matter experts, as Travis and Patrick, I think have really been a great help for thinking about Virginia and how we can roll this out. And we're still, as long as we can get reimbursed, I think we'll have some interest in pharmacies wanting to do this. So that's our fingers are crossed that we can ensure that they can be part of the network, because if they're considered out of network, they will not be reimbursed very well, or they won't be receiving patients and they get paid. So that's our goal.
Yeah, as pharmacists, we know what we can do. We don't do the best at selling it. We've got a captive audience with our state health departments, and so we've been putting them in touch with as many SMEs like Karen and others to understand how this works. And of course, we don't know exactly how state health departments work for the most part as pharmacists. And so this has been a mutual collaboration and a win-win for some of these opportunities. And so we will have additional billing. We are working on billing resources that will be a little more efficient in explaining like some of the pathways to reimbursement, because we know pharmacy has a unique pathway forward. We can't just assume that it's the same for pharmacy to be reimbursed as it is for some of our other healthcare partners, and even our non-healthcare partners. When it comes to National DPP, we have some different steps to jump through. And so making sure everybody's on the same page is really important at this point.
And I would like to follow up. I'm Teresa Salgado Rob. I'm in the classroom, so
Yep.
you might see me very tiny. But I really wanted to, follow up on what everyone is doing. One of the big challenges, whether you're delivering the DPP through the community or through other means, is really the retention of the participants. And so we offer a huge resource and a big value proposition through the model that we've created here in the School of Pharmacy, where we're training our pharmacy students to be certified lifestyle coaches. And so having said that, in our DPP programs, the ones that we have going on within the school, we pair them individually, as featured in the CDC brochure. We pair them individually with each of our participants. And we have seen some really good results in terms of retention, in terms of making up some of the sessions that they may not be able to attend. And so we created a system to track everything that the coaches are doing in between sessions. And so as pharmacies become more involved and as we expand this model through the state, I would love for us to consider this as one potential implementation strategy, which is pairing individual participants with a lifestyle coach. And, all of these students are eager and excited and knowledgeable to serve as their point person in between sessions. But really this as an implementation strategy to really solidify whatever it is that we're growing in terms of program and ensuring sustainability. So the billing aspect is one aspect, but then as far as the participants are concerned, making sure that we get them through the door, but also that we help them and we coach them and we support them throughout the program is also critical. And so, we've had conversations with Karen, we've had conversations with John Beckner from NCPA. And so, yeah, any opportunity we have to pair our students with the participants would be great, I think.
I agree. You guys are doing something unique, and that's why we highlighted it. And because hopefully that is something that does catch people's attention, and they say, "Hey, this is an opportunity." We know that getting people enrolled in a program or in a retention activity is challenging to begin with. And people, by nature, I think I can say that they want to treat something that they take a pill for something, or they treat it and they actually see a tangible result. Preventing it's a little bit more proactive, and we struggle just by human nature, I think, to be involved and then to be retained for a year. Boy, you're really asking for a lot, but we know it takes a year to build these new habits and really get your lifestyle adjusted to a different way of doing things. And we've seen the most successful National DPP programs, lifestyle change programs, come down to lifestyle coaches. The more dynamic a coach is, the more engaged the participants are, and the more likelihood they are to be retained. A lifestyle coach, that puts a lot on their shoulders, but having an additional touch point, like you're mentioning here with the students, or a community health worker, doing those one-on-one encouraging, coaching, supplemental activities that keep them, feeling like that somebody's going to follow up with them, that they really need to have that encouragement of whatever source makes a lot of sense. And having it from a student, I love the idea. I really do. It sounds like it's got great potential for a broad application.